Good evening, everyone. I'm Jan Rock with the DCM Foundation. I'll be your host this evening. We're just giving a few more seconds here for people to join. Thank you so much for being with us. Tonight's webinar is Cardiomyopathy, Genetics, and You. And again, we'll begin in just a moment. See, more people are hopping on here. A lot of interest in this topic. We have a lot of registrants for tonight's webinar, so we're so glad you have interest in the topic. So let's get rolling. Again, we're here for the webinar Cardiomyopathy, Genetics, and You. We're going to talk about getting better care, getting genetically tested, and getting more involved. This is part of the Genetic Cardiomyopathy Awareness campaign, and you can learn more at geneticcardiomyopathy.org. Next slide, please. So it is June 21st, the longest day of the year. We made it. Thank you again for joining. All participant microphones are muted so that we can clearly hear tonight's speakers. Please use the Q&A feature if you have any questions. Next slide. An open Q&A session will follow tonight's presentation, so please put your questions into the Q&A feature at any time. You don't have to wait until the end, and we will get to those questions during the Q&A portion of tonight's event. Next slide. So first, we have a poll. We usually run this poll. We'd like to know who is attending tonight's webinar. Are you a cardiomyopathy patient, a family member or friend, a medical professional, or an industry professional? This just gives us an idea who's in the audience tonight. Just give it a second. Great, if we could end the poll and share the results, and it's Justine helping us behind the scenes tonight. Excellent, so we have almost 60% of tonight's attendees are cardiomyopathy patients, which is great. Family and friend, 12%. Medical professionals, about 14%, and industry professionals at 16%. So we have a great mix and a lot of patients, which is fantastic. So let's continue on. We have a lot to get through and an exciting lineup of speakers. Tonight's topics and speakers include a GCAC overview, and that stands for the Genetic Cardiomyopathy Awareness Consortium, which you'll learn more about from Greg Roof, our Executive Director of the DCM Foundation. Many of you may already know Greg from prior webinars. Greg will then also talk about getting the best care for your cardiomyopathy. And then we have a guest speaker, Elizabeth Jordan. We're very excited she could join us tonight. She is a certified genetic counselor, and she will talk with us about getting genetically tested. And finally, we will talk about how to get more involved. And covering that topic will be Adam Burkhart, our new Director of Patient and Family Services for the DCM Foundation. And we are just so thrilled that Adam has joined us. So let's continue on. So first, a quick overview of Greg before he covers how to learn more about genetic cardiomyopathy and getting better care. Greg is the Executive Director of the DCM Foundation. He is a genetic DCM patient, and he received a heart transplant in 2021, almost 2 years ago now. He was diagnosed with DCM in 2014 and required an ICD, then learned that he had 3 mutations responsible for his DCM, and that was through genetic testing, which we're going to talk about tonight. A number of his relatives then also learned that they carry similar genetic mutations that can cause DCM. In 2017, Greg launched the DCM Foundation to bring education, hope, and resources to DCM patients and their families. And in 2023, Greg and the DCM Foundation, with the help of 9 patient partner groups and leading biopharma companies, launched the Genetic Cardiomyopathy Awareness Consortium, which is really has a goal to bring awareness to the genetics of cardiomyopathy. It's an incredibly important topic. And so let's continue on. Greg, the floor is yours. And we're so glad everyone could be with us tonight.
Yeah, thanks so much, Jan. Thanks, Justine, behind the scenes. Adam and Elizabeth very much. And thank you all for attending this evening's webinar. And first of all, we're going to give, this is our second of 3 webinars we have this year about the GCAC, or Genetic Cardiomyopathy Awareness Campaign and Consortium. And Jan said a little bit about that consortium, but Justine, next slide, please. First, I want to give you a bit of an overview of GCAC. And we were finding that there wasn't enough awareness or knowledge in the patient community and cardiomyopathy patient community, and also the medical community, about the role genetics plays in cardiomyopathy. So there were 8 US groups that have created GCAC, or the Genetic Cardiomyopathy Awareness Consortium, and sponsored by a number of leading biopharmas, and we have some other partners also, we're going to show on the next slide in a minute, created this group to create a genetic cardiomyopathy awareness campaign. What we hope with this campaign is that we will hopefully save lives and advance therapies for treatment for cardiomyopathy. We'd love you to join us in our campaign and spread the word. Adam's going to give in his part of the presentation a little more information on how you can join in and help support the campaign. And our slogan with GCAC is why would you get genetically tested? Why would you get your family members potentially genetically tested? And it really is to help yourself, myself, your family, my family, and your legacy, my legacy. So really participating in the campaign not only helps yourself, your family, but all the other cardiomyopathy patients around the world. Next slide, please. Here's a quick view. And again, we thank you so much of all of our corporate sponsors: Tenaya, Bristol Myers Squibb, Pfizer, Nuevacor, Cytokinetics, CTI, and Lexeo. We very much appreciate the support and the partnership of our patient partner groups: Children's Cardiomyopathy, Global Heart Hub, Hypertrophic Cardiomyopathy Association, Heart Brothers, Men at Heart, SADS, Team Titan, and Women Heart. And we've got some great partners that help put this campaign together, including the National Society of Genetic Counselors, the Cardiogenomic Testing Alliance, and the American Association of Heart Failure Nurses. Thank you all so much for your partnership and support of this campaign. Next slide, please. You know, why is this campaign important? And essentially, for several reasons. The problem is that we now know that up to or about 50% of cardiomyopathy has some type of genetic cause. As we learn more about genetics and cardiomyopathy, that percentage is going to increase. But right now, we're saying about 50% of cardiomyopathy has some type of genetic basis. But a recent study by United Healthcare and Invitae showed that only about 1% of cardiomyopathy patients are getting tested for their cardiomyopathy. And by getting more patients genetically tested, if they have what we call idiopathic cardiomyopathy, or you have cardiomyopathy that was not caused by a heart attack or coronary artery disease, you should get tested. And with this, you can save not only your life by getting treatment. Some genetic cardiomyopathies have arrhythmias, so getting an ICD in place could potentially save your life or a family member. But also, you know, in order to create genetic therapies in the cardiomyopathy world, we need to get more people tested and willing to be in research studies and clinical trials. Next slide, please. The next part, so that was the overview. Hopefully for those that haven't been on our website or didn't see the first webinar, you get a kind of a general understanding of GCAC and what we're trying to accomplish. But now the section that I'm going to go into really is about getting the best care. Next slide, please. The next slide, as you can see now, is a poll that we'd like for you to take. And we're sort of interested in saying, of the patients that are here, where are you getting your care? Do you get it from a general physician for your cardiomyopathy? General physician, through a general cardiologist, through a heart failure specialist not associated with the heart failure center, a heart failure specialist associated with the heart failure center, or lastly, a heart failure specialist at a heart transplant center. Please complete that, a bit complicated poll, but please complete that now. We'll give you a few more seconds. Thank you, Justine. Let's show the results. So it's interesting. We see that nobody is getting their cardiomyopathy treated through a general physician, which is good. About 29% are getting it through a general cardiologist. 18% are with a heart failure specialist not associated with a heart failure center. Another 29% are at a heart failure specialist at a heart failure center. And about 24%, or a quarter of you, are actually at a transplant center. This is great. Thank you. Next slide, please. Why is it important? And looking at the results of the last slide, it's interesting. It's pretty much a mixed bag. But we think it's really best that if you have cardiomyopathy, it's best to try to go to the absolute best center you can to get your care. Cardiomyopathy or heart failure affects around 2 million people in the United States each year. And many cardiologists, where they may be generalists or good at certain things, putting valves in, stents, things like that, may not be heart failure specialists. So we highly recommend, as a dilated cardiomyopathy or a cardiomyopathy patient and family group, that if you have cardiomyopathy, that you really try to go to a heart failure specialist. And especially if you have genetic cardiomyopathy, the better heart failure center that you go to, potentially the better treatment that you will get. And if you have genetic cardiomyopathy, as I mentioned before, going to the best advanced heart failure centers where you're going to get the best care. Next slide, please. Thank you. And so a question always is, I'm at a cardiologist. I wouldn't mind seeing a specialist or going to an advanced heart failure center. How do you make that happen? One of the questions you have to first ask yourself is, do I need a referral? And one thing that you can do is call and ask your insurance company. Some insurance companies require that you get a referral to go to a more advanced specialist. Sometimes they don't. But first thing you ought to do, if you're thinking about going and seeking a heart failure specialist, that you should call and ask your insurance company. If they require a referral, whether they require for a referral or not, go ask your cardiologist. Say, hey, I'd like to go someplace that treats really advanced heart failure. Who do you recommend? So you can ask your cardiologist or physician for a referral also. Next slide, please. And how do you find an expert care near you? Now, we're going to show, like the Hypertrophic Cardiomyopathy Association done a good job putting a list of specific heart cardiomyopathy centers around hypertrophic cardiomyopathy centers around the country. We haven't gone that first for GCAC, haven't gone that far, but one easy way to look for an expert heart failure or cardiologist for cardiomyopathy is really to just go in and Google search heart failure centers near me, or Google search heart transplant centers near me. They're great ways, and they'll bring up folks near you. Many of them are academic centers that are heart failure centers or heart transplant centers, and those are an expert place to find good care. You can also go to MediFind, which we have a relationship, and look for specific types of cardiologists, whether it's dilated cardiomyopathy or hypertrophic or left ventricular. You can search on those things, and you can also visit DCMfoundation.org to find a specialist. Next slide, please. Also, I talked a bit before. If you have a particular type of cardiomyopathy, whether it's hypertrophic, your child has cardiomyopathy, SADS, which is arrhythmogenic, and with our other partners, please visit their websites because they may have more detailed information on getting the best care for your type of cardiomyopathy. Next slide, please. That is it on getting the best care. And, we really think that you should look at looking for a heart failure center or a heart transplant center to try to get your best care. You don't necessarily have to look for the perfect doctor. When you have heart failure, you tend to be treated by a team. So looking at probably the best center is a great way to go rather than looking at specific cardiologists. Jan, please tell us about getting genetic cardiomyopathy tested. Thank you.
Great, thanks so much, Greg. So let's get into learning more about getting genetic testing for cardiomyopathy. Next slide, please. First, we're going to conduct another poll. Justine, if you could kindly push that forward. Have you had genetic cardiomyopathy testing? Yes, no, or no, but I'm planning on it. So this will be interesting. This is obviously for the patients and their family members participating tonight. Great, if we could end the poll and share the results. This is fantastic. So 65% have said yes, 20% have said no, and another 15% no, but I'm planning on it. What's really striking about these numbers is that you will see we talk about only 1% of people with cardiomyopathy get genetic testing done, and that is in the general US population. We find that our constituents, folks who attend our webinars, tend to be a little bit more sophisticated about all of this, and that's represented by this number here of the 65%. So what we're going to ask of you is to spread the word so that others now will also know about the need for genetic testing for cardiomyopathy. Great. So let's continue on. And again, you're going to see this number here. Why should I get tested? Well, nearly 50% of all cardiomyopathy cases in the United States are likely inherited. And only 1% of cardiomyopathy patients actually get testing done on average. So this is a huge discrepancy. We need more people to be tested, and it can help save lives. So please help spread the word. Adam will talk with you more about how to do that. But just a reminder that the American Heart Association and the American College of Cardiology both recommend genetic testing if you have cardiomyopathy of an unknown cause, which is idiopathic. Next slide. So how can you get tested? You may have a cardiologist that has told you that they don't have access to genetic testing, or they may actually refuse to test you. I saw a question just come in, and we hear this all the time when we're talking with patients, and we see it in cardiology support groups on Facebook. People will ask their cardiologist if they can be genetically tested, and they will actually refuse to do that. But you can get tested on your own. And we'll talk a little bit more about this, but Genome Medical will see if your insurance will pay. Through Genome Medical, you will also speak with a genetic counselor, and they will send a simple spit test to your home. You spit in the tube, you send it back. It's a very simple process. And if insurance does not cover this, your cost is approximately $600, which covers 2 genetic counseling sessions, pre and post test. You'll get 1 pre and 1 post test counseling session, and the test itself is included in that $600 range price. You may also want to ask what your out-of-pocket cost will be if you self-pay. Sometimes self-payment is actually less expensive, so definitely investigate that. For more information, please visit geneticcardiomyopathy.org. It has all of the information and the steps to walk you through, and it'll bring you to a Genome Medical link that you can click to learn more about how to go about testing. Next, please. So next, we're going to talk about genetic testing and counseling for cardiomyopathy. And for this portion, I am thrilled that we have with us Elizabeth Jordan. Next slide, please. Elizabeth is a genetic counselor. She is also the associate professor in the Division of Human Genetics at the Ohio State University Wexner Medical Center in Columbus, Ohio. She is a certified genetic counselor at the Cardiovascular Genetics and Genomic Medicine Clinic and Inherited Arrhythmia Clinics at the Ross Hart Hospital. Professor Jordan received her genetic counseling training at Emory. In addition to her work as a certified genetic counselor, she is a co-investigator in the DCM research project, which she will mention a little bit more in her upcoming presentation. So without further ado, I would love to present to you Elizabeth Jordan. Thanks so much for being with us. We really appreciate your time tonight.
So I trust someone will tell me if you can't hear me or see my slides.
We can hear you and we can see you, so we're doing well.
Good. Well, thank you so much, Jan. It's great to be here. Tonight, I will be speaking a bit about the process and things to know about getting genetic testing for cardiomyopathy. And Greg and Jan have highlighted some of this already, but it's important to understand before we talk about the operational aspects of genetic testing about why this even matters. And the answer to this important question is that identifying a genetic cause can help inform your care, as well as help your at-risk family members prevent or reduce their cardiomyopathy risk. And because the more we know about the genetic causes of cardiomyopathy, the more we advance the field. So this can include our provider knowledge base, development of resources, and then also furthering research initiatives. And if your cardiomyopathy is of unknown cause, sometimes termed idiopathic, as has already been discussed here today, it's expected to be due to a genetic cause. And what I mean by genetic cause, a bit of background. So there's more than 20,000 genes in our DNA, and each gene provides a unique set of instructions for how parts of our body look or work. Genes come in pairs. So we have 2 copies of each gene. One comes from our mother, one comes from our father. And if a copy of a gene that's important for the heart muscle is abnormal, this can cause cardiomyopathy or heart muscle disease. So this abnormal gene is therefore present from the time we are born. Even if this condition doesn't present until adulthood, this genetic risk is present from birth. So in the example shown here, the abnormal red gene copy was passed on from the parent in orange to their child in dark blue, indicating that this parent-child combination both have a shared genetic predisposition to cardiomyopathy because of this presence of this abnormal heart muscle gene that they both have. And because of the well-established genetic background for cardiomyopathy of unknown cause, there have been several organizations that have recommended a genetic evaluation for patients and families that are affected with cardiomyopathy. This includes the American College of Medical Genetics, the Heart Failure Society of America, and more recently, the American Heart Association recommended genetic testing for cardiomyopathy as well as other inherited cardiovascular diseases. And you'll hear me refer to genetic testing more broadly as a genetic evaluation rather than just genetic testing. And what I mean by this is I'm referring to the multiple components that contribute to the larger personalized risk assessment of both you and your family, which under a usual clinical model would be done by the collaboration of a genetic counselor and a cardiologist, and include the assessment of your personal cardiomyopathy history, your family history of cardiomyopathy and heart disease, an evaluation of other possible risk factors in combination with genetic testing. And altogether, this can provide your family's genetic risk assessment. And if genetic testing is recommended to you after the other components of the evaluation, meaning that your personal history appears to be a cardiomyopathy of unknown cause, and this is really regardless of whether you have known family members with cardiomyopathy or not, your cardiomyopathy is suspected to have a genetic background. if of unknown cause. So, for example, if you look at this family tree on the slide here, including 3 generations, starting with you and your siblings at the bottom, up to your parents, and then the grandparents on either side, you'll see an orange individual in each of the 3 generations, indicating that there's someone affected with cardiomyopathy in every generation of this family shown. So when the history looks like this, maybe you don't even need a genetic test to know that something is running in your family, making this more likely to happen to you. But the important question that genetic testing is used to answer is, what is that specific genetic abnormality in you and your family making this more likely? And how can that finding be used and leveraged to guide your care and prevent cardiomyopathy in future generations of your family, so this story of cardiomyopathy may not need to be told as the family continues to grow. So if you're in that group of people that's considering pursuing a genetic evaluation, there are a few important things to know before testing, and these are items that a genetic counselor would review with you in a more personalized way before you would get testing. And first is that there are 3 types of results: positive, negative, or uncertain. And each type of result has its own clinical implications for you and your family, which would be tailored based on the various components that contributed to your family's risk assessment that I showed earlier. And the limitations of genetic testing. We've come a very, very long way in this field, but haven't quite figured it all out yet. So as I mentioned, if you qualify for genetic testing based on the clinical assessment of your cardiomyopathy is expected to be genetic, regardless of what the testing finds. The chances of actually finding the specific genetic cause of cardiomyopathy depends on the type and your family history. So for example, in DCM in general, the likelihood of finding a genetic cause is about 1 in 3. And for hypertrophic cardiomyopathy, maybe closer to a 1 in 2 chance. However, even though the cause isn't able to be found in all cases, finding the cause for you and your family can be quite impactful for guiding your care and preventing cardiomyopathy in your family, making it well worth considering despite not always finding the cause with currently available testing. And as Jayanne also alluded to, genetic testing, the genetic testing part of the evaluation is easy. This can be done by either a blood or saliva sample, which can be collected from your healthcare provider's office or from home. And then that sample is then sent to a certified laboratory that will look for any abnormalities in known cardiomyopathy genes and DNA that's made from that sample. And based on what those genes look like, you'll receive a test result, which, as I mentioned, can be positive, negative, or uncertain. And after you get tested and have your genetic result in hand, a genetic counselor in collaboration with your cardiologist can help explain and tailor this result to you and your family to determine next steps. And this typically depends on the type of result you have. So in brief, if positive, this means that the cause of your cardiomyopathy was found. We know the gene, we know exactly what's driving this. And this information can be shared with your doctor. It can also be shared with your family, as each of your family members, minimally including your parents, brothers, sisters, and children, each also have a 50% chance to have the same genetic abnormality that you have. Your at-risk family members that share this genetic risk are recommended to have clinical screening, and that usually includes an imaging study like an echocardiogram and an EKG. And there may also be research and clinical trial opportunities that are unique to your particular genetic finding. If you have an uncertain result, this means that there was a unique change seen in one of your heart muscle genes, but whether or not this actually causes cardiomyopathy to develop or not, or if it's just something that's benign or unique to you, is really not able to be determined with the available information about that particular finding. So even though this is unclear, it's still suspected that your cardiomyopathy is genetic. So testing isn't necessarily recommended in the family for clinical purposes, but we do recommend family members still get screened even if your results are uncertain. So all first-degree relatives, parents, siblings, children should have their clinical screening or heart check even if your results are uncertain. And of course, research can help further understand what a particular uncertain variant may mean. And lastly, if a result is negative, that means nothing abnormal was found in the genes analyzed. The genetic cause of your cardiomyopathy, which we still suspect the cardiomyopathy to be genetic, could be located in a part of the gene that isn't looked at with current testing, or could be in an undiscovered gene currently. Again, since the cardiomyopathy in you is suspected to be genetic, we still would recommend that your family members get screened, as they could also be genetically at risk. And that screening includes imaging and an electrocardiogram or EKG. And research opportunities also are available for people with negative results. I recognize this is a lot of information, and this is what genetic counselors do every day in our clinics, and of course here at Ohio State, and through our research program, we're doing this all the time. Genetic counselors' goal is to help navigate this process for families and tailor it specifically to what you and your family need to know. And again, this starts before testing, where the genetic counselor, along with your doctor, review your histories, medical and family history, look at your risk factors, provide any education that might be useful, and make sure you understand the testing that's being done, and selecting the best test to ensure that you're being tested for all the relevant genes that, based on your personal history. And then after we have the report, you'll also speak with a genetic counselor often after you have your results to explain this in the context of your family, coordinate next steps, connect you with resources, and importantly, stay available over time as clinical genetics is continually growing and changing. If you are interested in accessing a genetic counselor, in addition to the resources that have already been shown in the program tonight, the National Society of Genetic Counselors has a website that can help you find an in-person genetic service closely located to you, or remote programs. You can access this tool through scanning the QR code shown with the camera of your phone. And the DCM Foundation, as they already provided, has or the Genetic Cardiomyopathy Awareness Consortium has a link to a telehealth genetic counseling service that can help you through this process. And this QR code will also take you to that same place. And of course, if you find yourself in the Columbus area, we'd be happy to see you at Ohio State University. And I won't belabor this, but just a general comment on cost, as this is a question that does often arise. There's often a fee associated with both the genetic evaluation and the genetic test itself. So the cost for either of these components can vary within service providers, labs, insurance companies. So it's difficult to provide a one-size-fits-all number, but this is also part of what a genetic counselor can help you with, identifying the best, most cost-effective, but also quality test for you. As Jan suggested, there are direct pay options where you don't use insurance, and some labs have a $250 to $300 cash pay price for genetic testing if you're not using your insurance company. There's a code I put in the bottom corner of the slide here as another resource that was prepared by NSGC, reviewing a lot of the major insurance and billing questions that can be useful if this is a concern of yours. So to conclude, the understanding of cardiomyopathy genetics continues to grow and evolve, and what you're tested for today may very well be different if you were to revisit testing in 5 to 10 years from now with the rate the field's growing. I spend a lot of my research time in the genetics of dilated cardiomyopathy, And with cases still that we suspect to be genetic still being unsolved, this leaves a lot of work for us to continue to do. And we're doing this through the Dilated Cardiomyopathy Research Project, which is a family-based research program of dilated cardiomyopathy. If you're interested in reading more about what we're doing in the study, you can access our website through this code here. And finally, I'll leave you with letting you know you and your family can do this. So you can take steps to protect your heart health through obtaining a genetic evaluation. This might have to start with you. So I encourage you to talk to your family about the shared genetic risk for cardiomyopathy and plan how your family can seek a genetic evaluation so you can take steps to prevent cardiomyopathy in your family and change the story moving forward of cardiomyopathy risk in the future. And with that, I will pass it back to the foundation. Thank you so much.
Thank you, Elizabeth. That was fantastic. So much information. And again, if you missed anything, this webinar is being recorded and we will send out the recording tomorrow. So you will all have a copy of this and you can share with others in your family and so forth. So let's move on, and we have a lot of great questions coming in. We're going to hold them until the end. So just a few more minutes. We would love now to talk to you more about getting more involved. And for that, we have with us Adam Burkhart. Next slide, please. Let me introduce you to Adam. We're so thrilled he can be with us tonight and that he is now an official part of the DCM Foundation. Adam is the Director of Patient and Family Services for the Foundation. He is a genetic DCM patient, and he received a heart transplant in 2000, which I am told is 23 years ago now, this September. So really amazing. Adam was diagnosed with DCM at age 6. He had a heart transplant at 17, and today he feels as healthy as ever. He did learn through this process that his DCM was caused by a genetic mutation that affects a number of his family members as well. He is married and the father of 4 children, 2 of whom have genetic mutations that can cause DCM. Sadly, his youngest daughter, Ro, passed away at 4 months old. It was a low point in his journey, but he said it serves as a reminder that every day is precious and a gift. And Adam is an amazing individual, very optimistic person and looking to make a difference in people's lives. Being with the foundation as the Director of Patient and Family Services is really fulfilling a dream of his to help other patients. So Adam, we're so thrilled you're on board with the foundation and we're so excited you could be with us tonight. So take it away.
Hey, thanks so much, Jan. Great job, Elizabeth, Greg. Thanks for everything, Justine. Jan, wonderful job. So yeah, thanks to everybody that tuned in tonight. This was a great turnout. I'm so thrilled to be involved with the Dilated Cardiomyopathy Foundation. I love everything the foundation is currently doing and where it's going. And I'd love to talk to you guys individually. I'll show my email here later, but about the opportunity, more personally on how you can get involved and the difference you can make as well. So as we stated, 50% of cardiomyopathy has some type of genetic basis. This is a staggering number. We just need so much help getting the word out. The importance of genetic testing. There's, that's just a staggering number. The American Heart Association, the American College of Cardiology, and the Heart Failure Society of America, all their guidelines all recommend genetic testing. So this is definitely something that is very important to so many people. The foundations, the colleges, the associations, they all back it. There is definitely a need for it and to potentially save lives down the road. Even with knowing this, there's only about 1% from the entire US population that does get tested. That number is also just way too low. Just the importance needs to be expressed. Not knowing, it does put patients and family members' lives in potential jeopardy. Once you do know that you do have a certain genetic mutation, proper steps can be taken, that day to prolong or treat the disease. So it's very important. And please visit geneticcardiomyopathy.org. Educate yourself and gain more information. Next slide, please. Patients can and do affect positive change. The more cardiomyopathy patients see our campaign, they will, two things. Hopefully they will ask their cardiologist or heart failure specialist about getting tested, because the importance is so, it's just so important to get tested. And as more and more people get tested, the researchers, the genetic counselors, the doctors, people will get a far better understanding of this disease and make strides in the right direction to find a cure. Also, seek to be tested on their own. If you're not currently seeing a cardiologist or a heart failure specialist, which everyone certainly recommends, look into it on your own. Genome Medical, there's other places out there. Certainly look into that. The more cardiologists and heart failure specialists hear about this from the patients, they will gain a better understanding of the role genetics plays in cardiomyopathy. They will also test more patients, which strengthen numbers. That is amazing. And their family members, because it is inherited. Also create better cardiomyopathy genetic testing programs. Nothing right now is perfect, but with more and more numbers coming in, things are certainly getting better. Next slide, please. So how can you help? Become knowledgeable, educate yourself, do some research. I think everybody kind of knows this, but be careful of some of the things that you do read on the internet. Make sure it's from a reliable source, things of that nature. But also definitely visit the GCAC website, www.geneticcardiomyopathy.org. Excellent people within this organization, and a lot of great research and things being done. Sign up your name, email to get GCAC info and updates. Stay up to date with things, webinars, information. It all helps. Also go to your own cardiomyopathy patient family group to learn more. There's a lot of them out there. Women Heart, HCMA, Children's Cardiomyopathy Foundation, the DCM Foundation. There's just so many, and all are kind of tailored to specific needs for patients. So, find the one that's right for you and get active in it. Next slide, please. Following social media, so much of the population, this is a huge part of everybody's world these days. Facebook, Instagram, LinkedIn, Twitter. GCAC is on a lot of social media platforms. Just follow Genetic Cardiomyopathy Awareness. And also share when something pops up. If you're following them, like it, strengthen numbers again. People will see it, people will get interested, especially for those who it affects. So social media is a great way to raise awareness and gather information. Next slide, please. Another way, personally, I absolutely love flyers. There's a ton of information in just a short, kind of a short couple page book, if you will. But, download flyers from the GCAC website. There's a lot of great information in them. You can print them off. You can email them, to your cardiomyopathy medical team, heart failure center, also to other friends, family, people you may hear along the way of, suffering from this disease. Information is so important. They may not know where to go. So this would definitely help them out. You can also email them, share on social media, share in any patient groups you currently are in, and also ask your medical team if they will share with their patients as well. Next slide, please. And also certainly become a GCAC ambassador. It's, there's a lot of need out there for getting the word out, and a lot of people that need help navigating through very difficult and, kind of confusing times. So if you're interested in helping, I would love to be in contact with you. My email there is on the screen, aburkhart@dcmfoundation.org. I would love to set up a time to either a phone call, Zoom, or just communicate through email. I'd love to help you out and get in contact with you. Next slide. So I thank you very much, and I'll turn it back over to Jan.
Thank you so much, Adam. Excellent job, excellent information. Just a note, the flyers that Adam mentioned will also be sent via email. We'll have links to those flyers in the follow-up email, which will be sent out tomorrow. So we are now in the question and answer portion of tonight's event, and we have a number of fantastic questions that have come in. So I'm going to jump right in and get rolling here. There are so many questions. Let's see. If Ambry tested 37 genes and all were negative, is this sufficient? I am now diagnosed, I'm going to not say this right. This is a different kind of cardiomyopathy. Elizabeth, how do you say this? Takotsubo? Subo? If Elizabeth,
yeah, I can address the question. Yeah. So I would say that it really depends on when you were tested. Be sort of channeling some of the things I was saying about the growth of the field, making sure that the testing includes all of the genes that in 2023 are known to be the major players in cardiomyopathy. So it's less about the number of genes and more about the timing of it. We always recommend in our clinical service that you check in with the person that did your testing about every year or so, sending a message in your MyChart or however you best communicate, asking if there's any updates to testing options. But certainly every 5 years is reasonable to really consider retesting.
Okay, great. That answers this other question about having had testing 8 years ago. Do I need to be retested? Had no counseling at that time. No genetic abnormalities were found. But again, like you said, every 5 years or so, people should be retested.
Yeah, and I mean, in 2017, we discovered a gene called FLNC that started making its way onto the panels and has now emerged as one of the major causes of dilated cardiomyopathy. So, you know, it does change rapidly, and ask the question every year. I think it's a good one to ask.
Excellent. A lot of these are for you, Elizabeth. How soon
One thing
do
I
you
want to add to that too, real quick,
Oh,
Jay,
I'm sorry. Sure, go ahead.
is, and Elizabeth mentioned it before,
Yeah.
you know, if you've been tested and it comes up negative, it's so important that you talk with a genetic counselor, because if there's 2 or 3, 4 people that have cardiomyopathy, right, there's something going on, and maybe the test is not finding it. They haven't discovered the gene. The test is not sensitive enough, whatever. But it's really, really important that you have a conversation with a genetic counselor, because they can help you uncover those things. There may be something going on. We just don't know what the answer is yet. So it's really, really important. And there was a cost question that was on before that said, hey, the test only costs $250. Why are you saying $600? Through the Genetic Cardiomyopathy Awareness Consortium, if you're not getting tested through your cardiologist or your physician, they do not have the capabilities for testing, or refuse to get you tested, but you think there might be something going on in your family. If you're getting genetically tested, you really, really should, at the very least, have a test results conversation with a genetic counselor. What we're doing in Genome Medical is there's a consultation up front with the genetic counselor to explain the test, a lot of things that Elizabeth explained this evening or this afternoon. And then they're also, when you get the results, I was tested, my entire family was tested. Trying to understand the complexity on your own is impossible and dangerous, I think. So and through our testing through Genome Medical right now, we require that you actually talk with a genetic counselor. That comes with some additional costs, but it's well worth it. So sorry.
No, that's fantastic. All great points. If you test positive for a mutation, will you still be able to get life insurance or health insurance? I'm sure this is on a lot of people's minds.
Really important one. Yeah.
Elizabeth?
Yeah, glad to chime in. So if you test positive, say it again, the exact question. If you test positive, will you be denied life insurance coverage?
Yes, and health insurance, actually. I think
Yeah.
you can't be denied health insurance at this point, but go ahead.
So yeah, there's the sort of high level answer is that there is some protective legislation in place called the Genetics Information Non-Discrimination Act that was passed in 2008. And there is some protection in there for things like health insurance, employers. But there are some limitations to that law, unfortunately. So things like life insurance are things that do not fall under the GINA as written. So it is important to consider if you are at risk for being discriminated against or being denied a policy. A couple of things to consider is that this is most pertinent to people who are unaffected and do not have any signs of cardiomyopathy but are getting tested. So this is, going from healthy to having a genetic risk for a condition versus people that already are affected have heart failure or cardiomyopathy of some kind. You will be asked to provide your medical history, which would also be something that the life insurance policies may take into consideration. So it is something we definitely encourage people to have in place before your genetic testing if it's something you're concerned about. And then also if you're considering having your children get tested who are healthy, it would be wise if you're able to get a life insurance policy in place to be completely protected.
Greg or Adam, did you want to add anything to that?
I think long-term care, I think also falls in that. So that is something. Okay. And, again, as Elizabeth said, if you've already been diagnosed with cardiomyopathy, you're going to get rated or it's going to hurt you for life insurance anyway. So if you look at if you're diagnosed, getting the genetic test is probably not going to hurt you anymore because, but an unaffected family member, secure the insurance before they get the test, basically.
Mm-hmm. Okay. This question comes up a bit. How soon do you recommend children get tested if the parent has a type of cardiomyopathy?
Also not, I don't have a one-liner answer, but I have an answer.
Go ahead.
So I would say that it depends on the gene, the family, the guidelines, the screening guidelines start as early as infancy. So if there is a genetic risk that appears to increase the risk in childhood, that genetic testing is something you can do in infancy or in adolescence. But in terms of the risk to develop cardiomyopathy, it often depends on the gene, the type of cardiomyopathy, and the age of onset in your family. Again, part of the conversation, a personalized risk assessment and recommendations that would be made by a cardiologist or in collaboration with a genetic counselor to help with the genetics piece.
Okay, great. And just a follow-up question. Another person asked, if one child has been diagnosed with HCM, what's the likelihood that their second child will be diagnosed with it?
So the chance that they share the same genetic risk is 50%. The question of the likelihood of them developing it is a different one. We know that all we can really predict is that there's a 50% chance that they share the genetic risk. But even if they share that genetic risk, we don't know with certainty when or if they will develop the disease.
Okay, excellent. Thank you very much. Have you used genetic tests during prenatal consultation, taking into account that a family comes to you with a positive family history of cardiomyopathy?
Yeah, that's one of the things I've seen evolve over the last decade of of genetic services that are available. So there's some really fascinating genetic technologies now where you can actually do genetic testing on a developing fetus, but also pre-implantation at the embryo stage. So if you know your genetic diagnosis, there's actually reproductive technologies now where you can test a embryo before it's implanted to see if it shares the same genetic risk. So certainly there's different levels. You can use it just as information. You can test a developing fetus, or even if you're looking to fully avoid passing on a genetic abnormality, there's some pretty innovative genetic technologies now where you can test before implantation.
Oh, incredible. That's incredible technology. Quick question, because we have a number of questions in the queue still. Elizabeth, are you available to go till 10 after if we want to continue to answer a few extra questions? Okay, great. Thank you so much. Adam, are you available for that?
Yeah, absolutely.
Okay, great. I know Greg is, so this is very interesting. This question comes in from Tina, who is very involved in one of our support groups and spreading the word out on the West Coast. She actually is involved with Cedars-Sinai, and she's going in with flyers and so forth, which is just amazing. Shout out to Tina. Tina says, from a general cardiologist initially, I was then sent to a heart failure specialist at Cedars-Sinai, a heart failure center, and a heart transplant center. However, when I asked for genetic testing, I was not supported, but I insisted on it. The results were negative at this time. What are your thoughts? Elizabeth?
I think this comes back to our question one. You know, persistence is always a good thing. Self-advocacy is a great thing. And then knowing when to recheck and having that's something that is set on your list of questions for your checkups about when retesting would be wise for you.
Wonderful.
And again, if you have idiopathic cardiomyopathy, excuse me, JM.
No, go ahead.
You're supposed to get tested. This is where, as a patient group, I can be a little stronger. All the major ruling bodies say if you have idiopathic, unknown cause cardiomyopathy, you're supposed to get genetically tested, but nobody is. The problem is that the vast majority of physicians, cardiologists don't understand genetics. And they don't have the capability of testing people. It's really an infrastructure problem. And so in general, you're going to have, this is an area where you're going to really have to be an advocate. That's why we're doing this campaign. If you have idiopathic cardiomyopathy, you should get genetically tested. Your doctor, your cardiologist may say, no, you shouldn't. I hear that weekly from patients, right? Then they get tested and they find there's a genetic cause. So I think this is an area where you really do have to advocate for yourself and you have to be strong, because this is a huge area that the medical community has not caught up with. And so this is, as Adam said, jump up and down, scream and yell, talk to your cardiologist, right? Let's educate them. This is where patients educate them. And you have to, as a patient, protect yourself here, right? Because the cardiology community is just not there yet. So.
Absolutely. Ornella writes, my husband died with ischemic heart disease, and my 10-year-old is diagnosed now with hypertrophic obstructive cardiomyopathy. Should I screen or do I not have to? Elizabeth?
Should, yeah. So sorry for the loss. And this is an example of some of the complexities of investigating heart disease in a family. Just because we can see both ischemic and idiopathic heart disease in the same family tree. And so this is a lot of what we in our clinic, Dr. Hirschberger, the cardiologist I work with here at Ohio State, and I will have to decipher some of this, and so it can be hidden. In any case, hypertrophic cardiomyopathy, because it has a strong genetic background, the recommendations would say that all of the first-degree relatives of your of your son. Is that was the
It was the
relationship, right,
son,
Jan?
10-year-old
Yeah.
son.
All of the recommendations would say that first degree relatives of someone affected with hypertrophic cardiomyopathy should all be clinically screened. So that would include both parents, any siblings or children to that individual.
Okay, thank you so much. Interesting question. Is the testing that's generally available based on genome from European descent mostly? Elizabeth?
Yeah, this is now we're gonna need an extra 20 minutes, Jan.
Oh,
This
okay.
is a
All right. I'm
very
so
important.
sorry.
It's a great, very thoughtful question, and is really important to how we interpret genetic information. We're improving in the representativeness of our our population samples, but by far the reference samples are, and patient representation in our in the literature are primarily of European ancestry. So this does limit our ability to more conclusively understand genetic findings that might be unique to patients of non-European ancestries. We're working on this in the DCM research project, but it is a very important initiative that should be carried through across all cardiomyopathies.
And then the follow-up question is, what can we do to have the traditionally underrepresented populations tested and cared for?
If I could start with that first, and that's a big part of GCAC, right? If anybody across the United States can get tested from their home, and hopefully the insurance will pay for it, or it's economical, what we really hope to do is increase the diversity. Obviously, geographic diversity, socioeconomic diversity, but most historical testing is done through academic centers, which, again, the people that tend to go there tend to be white, middle class, upper middle class, right, in general. I know with the DCM research study, they specifically targeted a lot of historically diverse groups, universities, or academic centers, hospitals, to get a much wider basis. But one of the things that we're trying to accomplish is in direct-to-patient outreach through GCAC is to create much more diversity, get people from all parts of the country, all walks of life, all races, and socioeconomic backgrounds. So, Elizabeth, I don't know if you have anything else to add to that.
I would just add that I think it's really complicated, and we owe a lot to the communities that have been mistreated by our healthcare system for a long time, in order to try to improve access and representation in both the clinical and research universes. And it's a multifold issue, and whatever we can do in the clinical and advocacy and research communities, we should all be doing our part.
No, great questions. Thank you to Valerie for those questions. Brenda asks, I can't spit in a tube. Is there a swab method to collect saliva? Elizabeth?
You have that?
Yes.
Good,
Yep.
good.
You can cheek swab, tube spitting, and then a blood draw.
Okay, beautiful. This person says, tested positive for FLNC truncating variant through cascade testing. It is very challenging to get good information regarding what to do from cardiologists. I am reluctant to potentially put my young adult children in the same situation. Any suggestions of what and or how to have a conversation with my children? And their children, they say, are young adult.
I actually use FLNC as an example already, and it was one of the genes that we have learned about very rapidly and has quickly emerged as a major cause of dilated cardiomyopathy and arrhythmogenic cardiomyopathy. But with that, maybe some public-facing information may be lagging, since we've only been testing for this gene for the past 5 or 6 years. So I would say I would encourage you to make an appointment with a genetic counselor. There's a lot of nuances about how to talk to your family, how to access the testing needs for your kids based on what resources you have. But this is exactly what we do, is help you navigate those family issues and support you through that, and figure out what resources might be useful in that conversation.
No, that's fantastic. Thank you. I will also just point out that if folks go to geneticcardiomyopathy.org, we have one of the tabs at the top is important conversations, and it's about how to talk to your family and how to talk to your doctor. And those are flyers you can download. I will also be sending those in the follow-up email. But again, thank you for that question. What are the chances that you will be the first person in your family to have a mutation? That's an interesting question. Elizabeth, again for you.
Every gene sort of has its own likelihood of where we see more frequent new mutation rates, or what's more technically called de novo, you might see. But in general, most of the time, we find that these disease-causing variants actually end up being inherited from a parent. But it's always a possibility, and it's why we recommend, if available and the whole family's engaged, best case scenario is that we can test parents and get this completely sorted out so we know.
So this is a great question. Just to clarify, why, if genetic testing is negative in someone's family, that they have tested negative, why should family members need to be clinically screened? If it's negative, does that mean it likely isn't a genetic cause?
I'm so glad that question came up, because if there's one thing you hear today, it's that a negative genetic test does not mean that your cardiomyopathy is not genetic. It just means we didn't find the genetic cause. In fact, we can learn the most from people that have negative genetic testing, because that means that we clearly thought that there is a genetic background. Testing was recommended to you. So there's something unsolved about the genetic cause of the cardiomyopathy in you or your family. So the reason that we continue to recommend clinical screening for the relatives for a person that has a negative result is because we don't know, we suspect that genetic cause, but we don't know what it is. So since we can't go through and test your family members and say, yes, you share this genetic risk, you need screening, no, you don't need screening, we take a conservative approach and say, consider all of your first-degree relatives could possibly carry this unsolved genetic factor and continue to be checked, since we can't use genetic testing to figure out who shares this and who doesn't. But by way of determining that your cardiomyopathy is of unknown cause, that's the cardiologist's way of saying this is likely has a genetic background and we should treat your family as if they're at risk.
Absolutely. Excellent. Why would a doctor refuse genetic testing? And this is a great question. Greg, do you have an answer for that?
Again, I think there are so many cardiologists that are completely uneducated, especially if they're older. They didn't get genetics in medical school. It's not something they dealt with. I mean, genetics are a relatively recent sort of discovery. And I think the younger people coming out from medical school, younger cardiologists probably have a better grasp on it. I think that's at one, they just don't understand it. And two, what I see is they don't have the ability to test or interpret results, which is a problem. And three, my belief, again, as a patient family person, not a medical person, I think our medicine has been developed to treat symptoms versus the cause. And so they're spending a lot of time saying, their belief is if the treatment's not going to change, what difference does it make? But the reality is, if you have genetic cardiomyopathy, a number of the genes have arrhythmogenic components that can cause sudden cardiac arrest. That would be a case where you would get an ICD implanted, and it would change your course of treatment. But I hear it weekly. We hear it weekly from people, you know, that a lot of the cardiologists just refuse. And it's just a lack of knowledge. That's why it's so important to get to a good heart failure center. They're going to understand this better. The ability to be treated better, you know, goes way up if you move in that direction. So
there's an added comment here that says, or they may think it's cost prohibitive and they therefore don't want to suggest it. So that could come into play, but I do think a lot of it is the lack of education.
Here's something else, and that we'll maybe end with that, but there is a cost to it. But I went through heart failure cardiomyopathy for 7 years and then was transplanted, right? I know that if you have cardiomyopathy, you're going to either, if you don't have health insurance, which is terrible, you're financially, it can be ruining. If you do have health insurance, you are probably going to max out your out-of-pocket each year because all the tests are expensive, all the procedures are expensive. So if it's a $5,000, $7,500, $10,000, there's a pretty strong chance that you're going to max out that. The cost of a genetic test in comparison to that is not that much, even though there is an additional cost. But the medical community, I hear this a lot, believes that like it's a lot. Well, how much does an echocardiogram cost? How much does an ECG cost? How much does it, right? You're paying for those anyway, but getting that genetic test if you have idiopathic cardiomyopathy potentially could save your life. It is additional cost, but it's nominal, you know, I think in compared to a lot of the other costs that you're spending, you know, every year dealing with heart failure and cardiomyopathy.
Thank you. This person says, my son has HOCM. I was tested by a cheek swab and it was negative. Should I get tested by blood work to see if I carry the gene? We have no contact with his dad, or is it more likely it came from his dad's side? If this person tested negative. Elizabeth, what are your thoughts?
So in general, I mean, it's hard to say without seeing all of the story, but I think the central question here is the accuracy of blood versus saliva or cheek swab based testing. And in general, the quality of the test result and the ability to detect genetic abnormalities in both sample types is the same. The only drawback sometimes for a saliva or buccal based test is just getting enough DNA to do the test, but you would know if there was not enough DNA to do the test, because if it's done at a certified laboratory, they have quality standards where they test to make sure that enough DNA is being created to accurately interpret the result. So if the testing was ordered appropriately and done appropriately, in terms of the genes that were ordered and things like that, the accuracy of a saliva test versus a blood test would be the same. I think that's really the central question here, under the assumption that all the right tests were done.
Wonderful, thank you so much. I'm going to wrap up the Q&A there because we've already gone over time, and I just thank everyone for their amazing questions. If you have questions that weren't answered and you would like them answered, you can email us at info@dcmfoundation.org and we'll try to direct you to the right resources or get answers for you. But thank you so much to all of our wonderful presenters tonight, to Elizabeth, Adam, Greg, and thank you to Justine behind the scenes. We have just a few more slides. So if we could continue on, just thank you to our generous sponsors. Without their support, we would not be here. Their names, all you see on the screen: Tenaya, BMS, Pfizer, Lexio, CTI, Cytokinetics, and Nuevacor. Next slide. Learn more about genetic cardiomyopathy at geneticcardiomyopathy.org. Sign up to receive regular updates. Follow us on social media. Spread the word. Share the information with others. Next slide. And we have an announcement that the week of June 26th through July 2nd, so starting next Monday, is Global Heart Hub's Cardiomyopathy Awareness Week. This is about genetics and cardiomyopathy. This is being launched in 10 languages worldwide. I'm getting dyslexic at this hour, I guess. Watch for more information, like and share these posts with others, really spread the word. This is a global effort now. So really excited about the partnership with Global Heart Hub. Next slide. And save the date for the next webinar, which will be held on Wednesday, July 19th. I will celebrate my birthday with you all. The topic will be DCM basics, causes, symptoms, and treatments. Registration is available on our website, dcmfoundation.org. We'll also send info in the follow-up email tomorrow. This is great for not only folks who are newly diagnosed and their family members, but also as a refresher for people who may just want to kind of learn more about the basics again. May have been a while since you've learned about that. So please, we hope you can join us. Thank you to everyone who could attend tonight and all the great questions. And again, thank you to all of our speakers. Hope you all have a wonderful night. Go out and enjoy the longest day of the year. Okay, have a great night. Thanks, everyone.